For this month's column, I wrote about what I thought were interesting meetings of the Oncology Drugs Advisory Committee convened by the U.S. Food and Drug Administration on two important topics. The first topic was regarding the bispecific antibody glofitamab for patients with relapsed or refractory diffuse large B-cell lymphoma, and specifically regarding the trial called STARGLO. So turning to STARGLO, STARGLO was the confirmatory trial for glofitamab. Glofitamab was previously approved by the FDA in 2023 for patients with relapsed DLBCL based on a single-arm trial that demonstrated an overall response rate of 56%. So STARGLO was a confirmatory trial in which patients with relapsed DLBCL were randomly assigned to receive glofitamab in combination with chemotherapy, specifically gemcitabine and oxaliplatin, or GEMOX, or the control arm of rituximab plus GEMOX. And the STARGLO trial demonstrated improvement in outcomes in patients treated with glofitamab GEMOX. Specifically, the overall survival was significantly better, as were other endpoints, including progression-free survival, complete response rates, and overall response rates. The toxicities were not trivial, but generally manageable. And so at that face value, one might expect, with an overall survival benefit, that the FDA would just approve glofitamab and give it a full approval in combination with GEMOX for patients with relapsed DLBCL in the second line. The problem that the FDA identified with the STARGLO trial is that of the 274 patients who were in the trial, only 25 of them were from North America, meaning that the study was largely conducted outside of the United States. 48% of the patients on the trial were from Asia. And in addition to that, on subset analysis, the North American patients, again, it was only 25 of them, but did not appear to benefit from the glofit GEMOX. And certainly that could be from an imbalance in patient characteristics. It was only 25 patients, so that subgroup wasn't balanced. But the FDA pointed that out and then convened the ODAC meeting with a very specific question, which was whether the trial results were applicable to the proposed population that the FDA is responsible for, namely people in the United States. So it's kind of a funny situation where a global randomized phase 3 trial demonstrated an overall survival benefit. So I think this trial may have implications for other studies, global international studies that are being done. And so I think, everyone is taking note of this as a potential marker for what needs to be done. And I think those designing studies and pharma and deciding where to conduct their studies is probably going to pay a lot of attention to this report and this ODAC result, and say, hey, we need to make sure with future phase 3 studies that we have significant representation in the United States if we want the FDA to approve this drug. So I think that's kind of the take-home message that may change how some trials are conducted moving forward. The second ODAC meeting that was of interest was regarding the monoclonal antibody daratumumab as a treatment for patients with high-risk smoldering myeloma, specifically regarding a trial called AQUILA. And the ODAC reviewed this one. The AQUILA trial, it was a trial for patients with high-risk smoldering myeloma, and it tested 3 years of daratumumab versus no treatment. I think most people agree that the standard therapy in smoldering myeloma is watch and wait. There have been 2 trials in the past that have demonstrated some benefits, but with controversial results. And so this was a trial testing daratumumab, and not the previous trials had looked at lenalidomide. So AQUILA trial tested daratumumab. It's a big trial, 390 patients with high risk defined fairly broadly. And the outcomes were that patients who were treated as opposed to not treated had improved progression-free and overall survival. So it's not a big surprise that progression-free survival was improved. It's fairly easy to do that in a trial where you're treating patients versus not treating patients. Of course, those who are effectively treated are going to have lower rates of progression than those who don't get treated. So that's not so interesting. But what was more interesting was that there is definitely a trend toward improved overall survival. However, the number of deaths was small, making the overall survival results, considered to be immature. And again, if you look at the watch and wait group at 5 years, 40% of them still had not required any therapy. So it's a little tough to know how to apply this to practice, because you're going to, if you treat everyone with smoldering myeloma, you're going to wind up treating a whole bunch of patients that would not sort of need any therapy for many years. And the toxicities of the trial of the daratumumab appear to be relatively manageable and consisted largely of infections and fatigue. So the ODAC reviewed this one. Really, a more straightforward question is, to do the benefits outweigh the risks? And they voted 6-2 that the answer is yes, which again is sort of interesting in a disease that can move slowly, where not everyone is going to need therapy. And so this was an interesting finding to me. We'll see how the FDA rules on that, but it looks like if the FDA agrees with the ODAC, that daratumumab may get an approval for patients with high-risk smoldering myeloma. So that's it for today, and thanks for listening.